Okay, having that said, this is a very ambitious title, and I wish that we'd have a situation where I could talk about this for like a day. It speaks to my heart, to my soul, to my brain as well, this topic. I've been working on this field for such a long time. But what I will do is, I may skip a few slides, but I will give you a couple of anchor points. And when I lose myself in track of time, I have a sort of a placeholder where we go next. Maybe so we go to the past, maybe go to the future, or maybe stand still and zoom in on the topic. And we'll start here as sort of an overview. Is we here in Turkey, but also in my little country in the Netherlands, but also in Canada or in Georgia and wherever in the world, we're facing the impact of geopolitical events on mental health and the challenges to mental health. This was 2024, it gets even worse, and beyond when we're looking at 2025. And the impact of geopolitical events will show us an increased incidence of PTSD and other mental health disorders due to recent geopolitical events such as the conflict in Ukraine, Israel, Gaza, and other hotspots. It seems trivial saying that, and I just came back from Ukraine, and we hear it day to day, we're getting desensitized in a way of the mass casualties and the bombing and et cetera, but it's going to, give an enormous impact on mental health, and it'll stay with us for quite a generation, so more generations to come. And there's just an impact of how many people it will impact and a cost. That's like very, very, very hard to assess. Now, at the European Psychiatric Association, and I'm happy actually not to have to be here, but I can move now freely. I learned that from you, Anil. That's much nicer that you can sort of walk around a little bit. This was shown at the European Psychiatric Association meeting in Madrid a couple of weeks ago. And what you see here is that these are words that are supposed to be disappearing from our discourse. And there's a lot of words here. And one of the words that you see here is trauma and traumatic, amongst many other words. And when you do that for a field of psychiatry or mental health, you're isolating a discourse that you cannot study, that you cannot talk about, which is at the heart of trauma research. Isolating it, not talking about something, disclose it, putting it under the carpet as if it doesn't exist. And I think that's a real danger when we do that and when we disappear these words in the new political administration that is going to be the dominant discourse out of the US. And when we start to behave accordingly, I think then we're in big trouble. So where do we go or where do we come from? Well, I come from here. Just, it was mentioned already, I have been wearing the uniform. I was the head of research at the time. We were both in Afghanistan, fighting a war very far, far away. When I was in Ukraine, the war was right there. It was felt. When I was in Israel, the war was felt right there. So it's different. And I always say, okay, I don't know what war is because I've only been deployed to war, but I haven't felt a war in my home country. I've been at peace. And for 80 years, our country has never been invaded except for when my parents grew up. Then it was invaded by the Germans. We've been occupied for 5 years. We see in the world, and I did some traveling in my time, all these global conflicts. And I show this slide quite often. I see, well, that's in Africa. That's from a patient of mine that drew his nightmares where he saw in Bosnia this child trying to be protected from the UN, but it failed. And that's a picture that I took from in Mali, I think it is, Gaza, Ukraine, and this is the fighting, the hands and the hearts, winning the hands and the hearts and the minds of the local people in Afghanistan, or eliminating the Taliban. And this picture haunted me for some time. I showed it, and I felt like, wow, a young girl with no limbs, right? And my zone is PTSD, and how will she lead a life after that? And that child, and somebody in the audience came to me once I gave this talk, or showed this slide, and he said, I know that girl. I know her. That's the girl. The same girl as I had in my slide that I was using. A couple of years later, this is the same girl at a cooking lesson. And here she is with 2 new, quote-unquote, legs, prostheses. But what I want to show with this picture is my zone as a psychiatrist in trauma is that everybody gets traumatized. But resiliency is much more common. People know to find their way to live a normal life. So the default is actually we're pretty resilient, despite the fact that trauma can be haunting you. And that's shown here. This is a very old slide from a person called George Bonanno. And he said, actually, if you look at populations that are being traumatized by a war or whatever event, you look at trajectory analyses, then you see that actually the largest group will be a group that can be characterized, if you follow them over time, by being resilient. And there's a group that was chronic, and there's a group that had symptoms, and they go to recovery. And there's an interesting group that has sort of mediocre symptoms, and they show symptoms as time progresses. That was confirmed by a recent study in Japan. We had a Fukushima, Great Eastern Japan earthquake. If you remember 2011, there was a nuclear disaster, a tsunami, and an earthquake, all at the same time. And there was a guy, Masanori Nagamine, who followed the first responders over 8 years until 1978. And he showed that actually what George Bonanno already predicted was similar for the Japanese. They showed the same symptom trajectories over 8 years. That's interesting. Resiliency is the default one. And this is a fun picture, for me at least. You see the same people. This is George Bonanno pointing at his slide from 20 years ago, and the new guy, Masanori Nagamine, showing his data. And then seeing that actually one sort of confirms the hypothesis by the other, and two researchers meet. That's kind of really a fun moment, I think. These are two people that actually show when we are being traumatized or being hit by an event, then this happens. This is a person, and this is the traumatic event, and it knocks you off your shoes, and then you're being, then you get an amplitude. And what they suggest here, the PTSD is actually the amplitude and the inability of the amplitude to come back to baseline. So some people stay there, some people, it takes a while before they go back, and some people really bounce back to baseline. And that's what they show here. PTSD is a specific phenotype associated with an inability to recover from actually the normal effects of trauma. This is Rachel Yehuda and Joseph Ledoux. And you can see that when you measure, this is growth hormone that we measured in some of Afghanistan veterans. You see here, this is PTSD. This is somebody who didn't have PTSD, sort of some mediocre symptoms, and this is a normal response to growth hormone during the night. This is a heart rate that shows the same thing, so it matters when you measure somebody for the outcome that you will measure. This is PTSD. Here are all icons or characters of people who are showing a symptom of PTSD. What I want you to take away probably with this one is this is the heart of PTSD. If you're not that familiar with PTSD research, this is the flashback. The flashback is driving the PTSD. It's the first symptom that emerges when somebody has an onset of PTSD. That leads to sleeping difficulties, bad dreams, start to avoid thinking about it, start to avoid talking about it, start to avoid going to places that serve as strong reminders. And we're pretty good at tackling that. As Rakesh said, we have apps, we have interventions, how to deal with this. The one that we are not that good with is this one, guilt or shame. I don't want to talk about it. I feel guilty about killing a child, or I've done things that I'm not proud of at all. I don't even want to disclose that I did this. That's very hard to tackle or to treat because there's often non-disclosure, or even if there is disclosure, how can you help forgive somebody for what they've done wrong? Forgiveness is something that I feel very incompetent in. It goes more to spiritual practices or so, that I need additional help for somebody to self-forgive. All right, this is a brain, okay? And this appears to be a healthy brain. So what we want to have in mental health is have a healthy brain. How can we keep our brain healthy? And we've heard from the speakers before that there are various techniques, digital mental health and Rakesh said measurement-based care. And this is probably a very nice way to find a metaphor for how we can keep our brains healthy by using our phone. right? We use our phone. When I use my phone to measure my bank account. How much do I have in my bank account? I feel good if it's okay, if it's low, and if it don't feel okay. But the telephone can also be a digital stethoscope. Think about the metaphor of the phone as a digital stethoscope. It tells you how you're doing. If you give it the right input, it can tell you you're good, you're struggling, you're coping, or you're overwhelmed, based on your own input. If the phone gives you a self-screener every day or so, you can see, like, how am I moving from the red into the green or from the green into the orange. I know this is a slide in Dutch. Doesn't matter, because many forces, defense forces, uniform forces, have used this mental health continuum to be used to tackle the difficult languages that we have in mental health for depression and for anxiety and stuff. They talk about colors. What is your color today? I'm green, I'm orange, I'm in the red. And red is not good. And you have several domains that you can assess on somebody's mental health functioning, and red is never good. What we did, and I referred to that in my question earlier today, with the United Nations, when I was working for the United Nations, we made a digital platform. And we gave an app to the peacekeepers in Africa and said, like, no, don't do this every day, but every week or so it'd be good if you just did a self-assessment, how you're doing. And then they could rate themselves. They could just non-disclose, but they could also see how they're doing. If they're going to be deployed for a year, they can see, hey, that was a difficult time because my mom died and I couldn't go home. And I did have some difficulties there. And if it's in the red, there's an advice, go and seek some help. Or look at these videos, or do some mindfulness trainings or so. It's called the UN's Mind Companion, but it's several of these apps are existing now. Oops, we did one in our hospital, we did one. It's called the Stress Buddy. When we were in COVID time, we gave our intensive care professionals an app. Let's call this app Healthcare, the Stress Buddy for Healthcare Professionals. And on these two, you see, this is the number of admissions that we had in our hospital. We peaked here, 3 peaks of admissions of sick patients, and we had another peak here. And these were the deaths in our hospital. And another peak here. And if you look at the reports of how resilient they were, or how burnout they were, or how depressed they were, they coincide with these events that were dramatic, because this was, as we all know, this was a dramatic period of having all these difficult patients. So we can measure, and an individual can measure, how am I doing in relation to Andy, or how am I doing in relation to all of us here, or my leadership can also see, how are all the IC professionals doing in our hospital? I think this is an example, this during COVID, Andy, that we discovered this, and I think this is something that, you know, is what digital mental health can look like. We had, and some of you were there, Guga was there, and Rakesh was there. We had a NATO advanced research workshop not that long ago in Tbilisi, where we looked at how much do we know about this digital mental health, and can we use it for the benefit of the soldiers in Ukraine? What do we know on AI techniques for detecting, he's got PTSD, he doesn't have PTSD, can he go back to the front, or do we need to give him R&R and go back home? Do we know any of that? Can we use it? Can we implement that? So we came together with all these professionals for 4 days in Tbilisi and looked at, do we really know, can we give it a sort of an avatar in a way? Like, if there is a psychologist in Ukraine on the front and she sees the patient, she doesn't have all the training, she just was finishing her psychological degree, and now she has to assess this patient, whether he can go back to the front or whether he can. Do we have enough measurement-based care or techniques to help her to decide what the strategy is for this particular patient? And we've gone pretty far, but it is so important that we need to have the trust from the Ukrainian armed forces to implement this app into the real world. Because if we take the wrong decision, that somebody may go the wrong harm's way. So the question of AI in digital mental health is also one and in traumatic stress studies is also very interesting. Precision diagnostics, we can use AI for the detection of PTSD. In natural language processing, probably you all use in your clinical, wherever you're working, AI to help you with summarizing your notes. I think that's nowadays getting very common. You can use Google AI to look at voice or facial expression or biometrical pattern analyses or digital phenotype via smartphone and wearable apps. And I just gave you the example of the UN's Mind Companion. We can also look at personalized interventions with EMDR or CBT with decision trees. What is the best strategy for you at this moment in time? We can look at adaptive digital therapeutics with the stress buddy or with other interventions that we have to look at real-time user responses. We can look at predictive modeling of treatment outcomes. We can accelerate research by doing large-scale trauma registries. I'll talk a little bit about network analysis in the end of my talk. And we can augment clinician support. If we have AI, it can really help you to make the right decision for pharmacotherapy or for sleep apps or for chatbots, as have been used also in Ukraine. PM Plus, as developed by the WHO, is one of these easy-to-administer interventions that can be very low-cost, high-scale for multilingual for support in low-resource settings. Okay, you've seen this before. That tells me, like, okay, we go somewhere else. We go to the past. If you allow me, I come from the Netherlands, not a poor country, small country, 17 million people. Maybe it doesn't speak to you, this picture. Somebody wants to try? It was the Canadians who liberated our country. Soon it'll come up. It's the beginning of May. May 5th is when our country was liberated. And the Poles came in one side and the Canadians came from the other side. And our country had been occupied for 5 years by the Germans. I wasn't even born there. My parents were 16 and 17 years of age. They remember that it's under their skin. And from an intergenerational perspective, it also got a little bit under my skin. Even though I've never been exposed to that war, I can feel it because we were always talking about it, or they were always neglecting to talk about it. One psychiatrist that was talking about the impact of wars was Jan Bastiaans. He was a professor at my university, and what he did before we had a name for this PTSD, he called it concentration camp syndrome. A lot of people after the war was fought came back, and some came back and survived the concentration camp syndrome, but there was no diagnosis for them. What he did, he labeled these people as suffering from concentration camp syndrome. These people were still locked in their minds. They were still not freed. They were not liberated. They were free, but their minds were not free. So one was he gave it a name, concentration camp syndrome, and the other thing that he did was very, very pioneering. He treated them with LSD. What is LSD? It's a psychoactive compound. It's a hallucinogenic drug. It's a psychedelic drug. He was the one that in the 70s and the 60s and the 70s treated patients with LSD to kind of free their brains from the fact that they are no longer in the camps. It's easier said than done. Nowadays, that's very popular to use psychedelics to liberate people and to open up their minds when their minds are still locked up in their trauma brains. There's some nice work, and there's, well, this is when you're excited about a topic and you can talk for long. This is about Eichmann and Yehiel Deneur in Israel. Everybody knows Yehiel Deneur, and there's now a documentary about Yehiel Deneur because he was treated by Jan Bastiaans with LSD, and he wrote a book about it. He was a very good writer. So that book is very popular in Israel, and we've translated it in the Netherlands. And now there's a documentary, it's called From the Return from the Other Planet. So we popularized this LSD treatment, but we can learn from the 50 years ago treatments of LSD by our current psychedelic practices that are becoming popularized as well. This was in the old days. This was, tape recorders. We don't have that anymore. This was the desk of Jan Bastiaans. He had all his medication here, and that was the couch, that was the infrastructure. We do it differently now, but that was, and then those days, that was his practice. But he said, LSD doesn't work by itself. It needs your cooperation to raise the events from subconscious memory to memory, and from memory to vision, and from vision to speech. So LSD is a catalyst for psychotherapy. It's not like a drug and then it heals itself. No, you need to do something when you're on board. It's a catalyzer. The incapacity to give words to experience is at the root of the soul's torment. That's the core essence of psychotraumatology, to give people the ability to talk about things that are difficult to talk about, whether it's cognitive behavioral therapy, EMDR, or things like this. So what we do with LSD and psychedelics, we reappraise, that's I think we do, the value of the transformative experiences. The transformative experiences, like I'm not in Auschwitz and I don't have to suffer from having survived. This was Stan Grove, this was Jan Bastians, but also somebody like Milton Erickson. And Mesut, we know Milton Erickson, right? Hypnosis has all the capacity to go to a non-ordinary state and kind of have an experience that actually has a profound impact on our daily functioning. And Bessel van der Kolk, actually, in his book, does kind of the same. Let's listen to one. Can you show me the second clip? Can you activate that? Before you do, hang on one second. This is a Marine that is on MDMA. And let's listen to what he says when he is on MDMA, when he is reliving an experience that his body just blown up, sea bass being hit by a mortar attack, and he sees his body being blown up in the Humvee, and he cannot rescue him. Can you go back and play the second one from the beginning? Yeah, that one. Yeah.
Bom fim, salve a Santa Bahia, imortal Bahia dos sonhos mil. Eu fico contente da vida em saber que a Bahia é Brasil. Dá licença, dá licença.
That's not the... Yeah, go back to the beginning. Okay, and play it. No worries. Okay. Are you getting there? Yeah, can you play? Yeah? I don't think we have sound. I'll read it for you, right? When he says, when I see it completely different now. I see it completely different now. Thinking about it, that moment that I got blown up, and everything was moving so slow. My mind was just racing at the speed of light.
I can really go back and visualize. I've never been able to visualize it so hard.
I can really go back and visualize.
Feel.
I've never been able to visualize so hard before. So what I'm trying to tell you is what he did, what I call a transformative experience. He goes back to the event and says, when I see it now, I really see it in a different way. I've never been able to look at it from that perspective. Typically, when somebody relives an experience, the frontal cortex is aired. The amygdala, the frontal cortex cannot inhibit the amygdala. The amygdala is on fire, and people don't want to go there. What happens here is the frontal cortex is on a vacation, and the amygdala is not active. So he can go back and visualize it. It's the start of therapy afterwards. He can now look at that from a novel perspective. And I think that transformative experience is at the heart of what we're trying to do in our trauma work. So when you see MDMA, and for the ones that have never seen this picture, this was a randomized controlled trial. You see here the blue ones that are on placebo. They get the same intervention. Blue is nice. They start at 80, and they go back into 60 after a couple of sessions. But look at the people who are using MDMA. They go below the threshold for PTSD detection, and they do not meet symptoms of PTSD symptoms anymore after 3 sessions. So in other words, what I'm trying to say is the transformative experience that they had while being on MDMA allowed them to be catalyzed by the experience and to work on their symptoms in a novel way that helped them to recover, in the line of thinking of Jan Bastiaans. Now, it's not 1 session of MDMA, there are 3 sessions of MDMA with integrative sessions reflecting on the transformative experience in a period of a couple of months. And in those periods, what we think, this is where there's a critical period. We call that a golden hour, where the brain is sensitive to the reward value of prosocial behavior. It's a really nice study in Nature, you can look it up, where the brain is not passive, the brain is really sensitive to what's happening there. The setting is really different than sitting on a chair. This is a mock-up patients. Here's a colleague of mine, time in Boston, Kirsten Rutter, and that's kind of the setting where we use MDMA in. Now, this is a busy slide, but there's a lot of these metacognitive, transformative shifts that people can say. I saw my trauma as part of a larger story. It helped me grow. Or I felt safe enough to share my story without the fear of breaking down. Or I felt I could step outside my trauma and see myself as a whole. Well, this can be self-reference, this can be self-compassion, meaning-making, acceptance, emotional processing, or decentering and cognitive distancing. We sometimes have that in our treatment sessions, right? Where people have that breakthrough, like, yes, if you talk about that, I can understand it, but I can also feel it that way. And it's transformative for me. That has been researched by eminent researchers. You see here pictures of people who are research careers, they're neuroscientists that look at the default mode network, global connectivity, reduction in ego boundaries, cognitive diffusion, and a relaxed brief under psychedelics. This is Robin Carey-Harris that came with that theory and is beautifully elaborated and talked about in research. Lisa Burback, and I can recommend you to go to her talk, because this is from her paper. She took, okay, what is new? We have these psychedelics I talked briefly about, MDMA, LSD, but we have in PTSD, actually, if we look at the categories of opportunities for treatment, we have quite a few at hand. And this is a beautiful paper that just came out 2 years ago. We have some compounds that we have in our hands, right? And as Rakesh said, yes, cannabis, we have cannabis. It's not that cannabis is a cure, but a little bit of cannabis can help people enormously sleep. We have psychedelics, but we have also these other adaptive disclosure, animal-assisted therapies, modifying exposure, telehealth approaches. We have techniques by currencies, direct current stimulation. We have transcranial stimulation therapy. And then we have a new category that is kind of new for our field, is spiritually focused therapies, trauma-informed guilt reduction therapy, or spiritual integrated cognitive processing therapy. These categories are relatively new, but these are giving hope, right? It's not that this is the box we have to treat you with. We have new approaches for difficult to treat patients. So if you zoom out and look, what have we been doing 20 years and what are we maybe doing now? When I was a resident, I was learning about behavioral therapy, behavioral modifications based on fear conditioning. And that has been changed to cognitive therapy, and what is emerging now in PTSD is these metacognitive shifts, experience-based somatic approaches to change strategies. Well, it's a mouthful, I understand that. That's a mouthful. But, and Lisa has not even seen this paper because I had the pleasure of being a series editor for a couple of papers that are coming out in the wonderful journal that Mesut is the editor of, the Psychiatry and Clinical Psychopharmacology, and this is one of those papers where Lisa went one step further, and she will talk about evolving psychotherapeutic approaches for PTSD beyond the fear-based model. And what we see there is a couple of categories. What we see is that we're optimizing existing trauma-focused therapies. That's one category. She's describing that in her paper. We're adapting psychotherapies used for other conditions, It's another category. We're reimagining exposure therapies, and we're using new therapeutic modalities, such as MDMA or others. So these are some of the emerging therapies. Horse-assisted therapy, we have virtual realities. I spoke a little bit, I mentioned cannabis. I have been using my patients with cannabis. And you may say, well, Eric, I don't like that. But a little bit, never too much. You don't drink a bottle of whiskey to be treated. No, you drink a glass of whiskey. That may be very helpful. So maybe a little bit of cannabis can be really helpful. But then you need to be at that level, right? We live in a country where cannabis is medicalized. We can prescribe cannabis, and we get reimbursement for cannabis. Ketamine was mentioned also. It's very exciting what's going on there. And I'll talk briefly on this one, which is a new kid on the block, briefly. 3-MDR. You may never have heard about 3-MDR. It is motion-assisted, multimodal memory desensitization and reconsolidation. That's why we call it 3-MDR. What is 3-MDR? It's a novel approach. Typically, am I doing okay with time, or how much time do I have? 5 minutes? 1 minute? 2 minutes? Oh, okay. So typically we're sitting, right? Andy is sitting there, and I'm sitting here, and we do talk to each other. But I invite Andy to come out of the chair and step on a treadmill. And on the treadmill, he's going to walk. And can you activate the first picture, the first one? Yeah, I'll just show you what happens here. The patient fastens the harness. Okay, and then he's being invited to step on the treadmill. And we call that mental warming up. And the patient is walking into a virtual space because there's a projection screen ahead of himself, and he's walking into that scenario. And he brings pictures of his past, and the pictures are displayed on that screen in front of him. And he is invited, as he is walking towards these pictures, to talk about what the pictures tell him as he's doing this. Now, I won't go, in the interest of time, to the whole infrastructure, but we have used this in the Netherlands, in Canada, in the US, and in the UK a lot. It requires a little bit of an infrastructure, but this is walking while talking. And that's called 3-MDR. And this one. An infrastructure, we call it an international consortium, where we use this novel approach to help patients, as Rakesh said, who are treatment resistant, that are not responding to any other intervention, but need some kind of help. And typically soldiers, officers, like walking. They like to do something. They like to sweat. They like their heart rate to go up. And they feel they have done something, not just sitting and passively talking, by doing something. Okay, see where we're going. Okay. Just seeing where we are. Okay. Can I use 1 minute? Then I will talk about this. I skip a few slides on MDMA, and maybe you've heard also in Turkey on MDMA. MDMA is one of these entactogens like LSD that can help catalyze patients who got stuck. But there was a negative advice to the FDA in America, and MDMA was not regulated as medicine. Now, we're in Europe, and maybe Turkey is part of Europe in that respect. What to do if you have a compound and you feel the compound is effective, but you cannot use it yet because of regulatory practices. It prevents you from using it in your practice. So we have organized ourselves into a European platform for the regulation of MDMA in clinical care, helping countries and academics to find a way to use these LSD-like compounds for some difficult-to-treat patients in a regulatory practice. And finally then, and that's my last slide, is neural networks. And I highly recommend you to go to the talk of my PhD student. Her name is Floor van der Does. And what she has done is really wonderful. She looked at what these large data sets that we can obtain with digital health techniques. When we have a survey and people are doing that on their phones, and we can look at all these hubs and how the hubs are interrelated and are changing over time. And when you do that with novel statistical techniques, we learn new patterns, new ways how symptoms travel together and which symptoms change sooner than later. For instance, dissociation or flashbacks. There are different trajectories that these symptoms have in going up and going down as you will be using your EMDR or your MDMA or whatever therapeutic technique. You need to have the software for that, you need to have the statistical expertise to do that, but then you can personalize medicine by these individualized networks, because your network is different than your network, and you can lump them together, but each network has its own specificities. Well, okay, with that, yeah, that's my I said I was in Ukraine. But you know, what touches me as a psychiatrist is to see something like this. When a country is hit with so much loss, right, and you try to find meaning in the loss, you need each other. And I was just walking on the street. I was doing much more than that, but and you see here the cohesion to carry the grief together, and that's kind of beautiful. So you can individually bounce back, but you need each other to bounce back, and that's kind of a message that I think stands not in contrast with the congratulations that I want to give the organizers as my very, 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 very last slide on the 20 years anniversary of the Turkish Association for Psychopharmacology. And with that, thank you for your attention.